Uh-oh, that's bad.
Okay.
Okay, so you all know me. I'm Andrea Pizer. I am a BK member and I'm also the founder of Aging in Montclair. But over the last 3 years, I have worked with some other BK people and some people from Shumray and Temple and near Tamid to do the Wise Aging program. And the Wise Aging program has been run several times in each congregation. It is an 8-week series, and we are going to do it again. From that, I have learned that it is a really valuable way for synagogue members to start conversations about the difficult or spiritually complex issues around dying. We focus on loss, on conscious dying, and on developing our own legacies. And we've during these sessions heard the members of these groups talk honestly about some of the troubled stories in the death of loved ones. My friends Karen Martineau and Tacy Silverberg-Urian have now made it easy for us to wrap our heads around the what and how of expressing our end-of-life wishes. And I'm pleased that they've brought us together for this, particularly at this time where we're pretty separated from each other. They're going to share some rich and meaningful stories, and I'm sure you have your own. But this is an opportunity for making or revising your advanced directive. And the goal is to check this off your to-do list, to not say, oh yeah, I got to get to that. Before I pass the mic over to them, I have to share why I have gravitated to end-of-life planning as part of my professional and personal practice. I'm the daughter of a woman who talked about her end-of-life wishes for the last 25 years of her life in great detail, raising it often, quite annoyingly to a teenager who didn't really want to hear it at that time. She must have rattled a bunch of lawyers when she asked them to include specific language in her will and estate planning documents. And it was now only that I realized, what a maverick she was. And apparently I must have listened to her because I think she got, in more ways than not, a good death. You'd think with this legacy, it would be easy to talk about death and dying and end of life. Well, it's not easy, but it's valuable. And workshops like this have made it easier for me to talk to my adult children, to my siblings, and to close friends who often get an earful. This is about comfort level and actually having the conversations and completing the documents. Then it's about continuing to talk to loved ones as we age, as we face health crises. And I guess this is my pitch for us to keep having conversations among ourselves with the people we love on these hard topics. So I now turn you over to the experts. Thank you.
Hi, everyone, and thank you, Andrea. My name is Tacy Silverberg-Urian. I'm a certified hospice and palliative care nurse and also a BK member. I'm also the chair of Essex County's New Jersey Healthcare Quality Institute Conversation of Your Life Task Force. We're charged with educating the community on the importance of completing one's medical advance directive. I founded Advanced Choices as a result of my years of face-to-face and hands-on experience in hospice and palliative care nursing. Too many times, as I met with families at the bedside, I witnessed both good and bad deaths. The good deaths were a result of families who were prepared with an advance directive. They were calm and knew exactly what their loved one wanted and experienced a more peaceful death. But the families who were unprepared had no idea what their loved ones wanted at their end of life. They were anxious, distraught, confused, and angry. This webinar was co-created with my colleague, Karen Martineau, who's the founder of Bible.com, a death literacy educational resource. Collaborating with Karen on this webinar has allowed us to bring a different vocabulary to the topic, something we believe offers you a richer learning experience.
Thank you, Tacy.
Who just did that?
I don't know. We just got lost.
I
What
didn't,
happened?
I didn't touch, somebody
Right.
shared a screen and
Uh-oh.
that wasn't me.
So can you mute everybody too when you're finished? Because I'm hearing a lot of
It said
background noise.
Jeff Martin did something, I think. It flashed by.
Hmm.
All right, I'm going to mute everyone.
Okay, I muted myself.
I think, Karen, you're going to have to unmute yourself.
Okay, I'm gonna unmute myself
There.
and, okay. And here we go. We're ready. So when Tacey invited me to collaborate, I got really excited because as a former creative director and producer, I've spent most of my career creating identities for entertainment brands, celebrities, fashion designers, and lifestyle products. And like so many other baby boomers, culture change is hardwired into my DNA. I'm part of the generation that created cultural revolutions, Watergate, Woodstock, civil rights, parenting, aging. And today's discussion actually began in the 70s when the right to die became a contentious ethical debate. Karen Ann Quinlan's tragic story ignited a conversation and an examination about how we die. After 40 plus years of questioning, we have accumulated enough information, knowledge, and tools to help us take control of our end-of-life experience. It was just before my 60th birthday when I came upon the term death literacy, which was coined by a team of academics at Western Sydney University in Australia to describe their end-of-life research. For these researchers, death literacy is a behavioral change. It means a person or a society has prepared for end of life long before the end. This webinar was structured to offer a kind of insight that will help you become familiar with the document, and it's a what, when, where, and how. Once we're done, you should have a clearer understanding of the practical and emotional issues that could arise. So thank you for considering and entering into this death literacy conversation with an open mind and an open heart. You should be better equipped to make hard decisions on your own after we're done, and as you work to complete your advance directive. Now, the informational portion of this session runs around 30 minutes. It's followed by a Q&A, and at any time during this presentation, please use the chat function to submit questions. Given most of you, or all of you, know one another, let's use the Q&A portion of this discussion to openly talk about things that matter most to us. So in order to get things started, I want you to use the chat function while I raise a multiple choice question. So here it is. Are you taking this webinar because, 1, you find the topic too difficult, maybe even impossible to address? 2, you've done your advance directive a while ago and you want a refresher before you go at it again. You're alone. This is number 3. You're alone and you might not have a support system to articulate what you want, your wishes. 4, perhaps your adult children or spouse doesn't want to talk about it, and so you're looking for a way in. 5, all of the above. So these are all real, legitimate reasons for avoiding the task. Historically, we've never developed a vocabulary or a comfort level to normalize these end-of-life conversations. But now that we're living longer and dying slower, how we die is on everyone's mind. So here's why advanced planning is valuable. I'm waiting for the slide. There we go. Having a plan can make the difference between a good death and a bad death. For a majority of people who don't know how to start this very important conversation, the 5 wishes is a gentle conversation starter, an opportunity to share your thoughts with friends and family. 5 wishes allows pre-consideration for ethical dilemmas that might arise. And lastly, it protects your loved ones from facing major decisions without any guidance from you. And it also avoids placing unnecessary burden on exhausted healthcare professionals. Tacey, back to you.
Yes. Am I on there? Okay. Yes?
Yes, your turn.
Okay. You may be more familiar with the term living will than an advance directive. They're the one and the same. Each contains the appointment of a healthcare proxy and choosing which medical interventions you want or don't want in certain situations. The 5 Wishes document is the most widely used legal advance directive in America. It's often called the living will with a heart and soul, because in addition to the required items on the standard living will, it goes beyond that, and it addresses the areas of comfort, how you want to be treated, and what you want your loved ones to know. And as a registered nurse with a specialty in end-of-life care, this COVID-19 pandemic was devastating to our medical community. For our patients and providers alike, having an advance directive document is critical. So let's begin by reviewing wish number 1 on page 4. And I hope everyone has the 5 wishes in front of them.
Tacey, you have to, yes, great. We weren't seeing you for a minute. There we go.
Okay. So choosing a healthcare agent on page 4, wish 1, is also referred to as a healthcare proxy. This person who will speak on your behalf if there comes a time when you're not able to speak for yourself. It could be your partner, adult children, or an adult friend. It doesn't need to be a family member, but it should be someone who you believe can honor your wishes. Your agent will protect your interests. Choose someone who will be assertive, someone who will ask the tough questions, not just defer to the medical team. So let me give you 2 examples of what I mean. My sister-in-law was dying of cancer, and she told me in confidence that she did not want her husband, my brother, to be her healthcare proxy because she knew that he did not agree with what she wanted. Instead, she chose her sister. So when the time came, she honored her wishes to stop medical treatments and be transferred to a hospice facility where she died a peaceful death. Another example is of an elderly female who I met, who lived in an assisted living. She was bedbound. She suffered from dementia. Her nutritional status was failing, so of course the physicians recommended an artificial feeding tube to provide nutrients. Based on previous discussions, her 2 daughters contemplated hospice, which is a type of service and philosophy focused on comfort. And together we reviewed their mom's advance directive, and it clearly stated she didn't want artificial feeding or antibiotics, but her daughters went along with the doctor's orders. They started her on the tube feedings, which eventually caused congestion, made it difficult for her to breathe, so they opted to discontinue the feedings, but continued a course of IV antibiotics, which required a longer hospitalization stay and painful daily blood draws. And after about a week, she was transferred to a hospice facility where she died only 24 hours later. And this was not the ending that she wanted. These stories highlight the importance of designating someone who accepts the responsibility of administering and managing your care. Some examples of the types of decisions your healthcare proxy will have are to provide consent to be transferred to an assisted living, nursing home, or hospice facility, to hire a care provider, advise the healthcare team about your choices around your medical care like tests, surgery, authorize or refuse medications or procedures to address your pain. Mind you, these are just common examples. You may think of something that isn't listed here. Add that note to the blank space provided. And if you don't want your healthcare agent to do something listed on this page, just cross it off. Now, you might be thinking, Can I have more than one healthcare agent? The answer is yes, but make sure they are on the same page. It is also a good idea to have a backup, just in case that person's unavailable. The healthcare team will call your second and third choices, respectively. Many people have said they don't have someone who could represent them. If that's the case, make sure you send a copy of your 5 wishes to your primary care provider and request a follow-up call or a televisit to discuss. If possible, bring a copy with you for your hospital chart if you are ever being hospitalized. Now, let's move on to wish number 2 on page 6. Are we there? Okay. Wish 2 asks you to think about the kind and how much or how little medical treatment you will or won't want. The section begins by requesting that food and fluids be offered by mouth if it's safe to eat and drink, to be kept clean and warm, and also not wanting anything done or admitted with the intention of taking one's life. Then it asks you to think about what life support means. Life support descriptions may be hard to listen to. Hearing what's involved in these very complex medical procedures requires you to think about each event, procedure very clearly. Life support interventions are aggressive. Oh, am I spotlighted?
No.
I don't know why I can't do it anyway. Okay. So let's review some of these definitions. Sorry. Life support includes the use of medical procedures, device, or medications to keep you alive. For example, a feeding tube, ventilator, dialysis, CPR, blood transfusions, or antibiotics. A feeding tube administers fluid and nutrients. A tube is inserted through a surgical abdominal incision or through your nose into your stomach to administer liquid tube feedings. A ventilator is a machine that administers oxygen. A large tube is inserted through the mouth and down one's throat to the lungs to aid breathing by pushing oxygen into your lungs. Just remember, once you're intubated, you can no longer talk. Dialysis is a machine that filters out toxins and waste when your kidneys begin to fail. The dialysis machine is connected to a surgically created atriovenous fistula, usually in the arm or in the groin via a long catheter tube. Dialysis treatments last upwards to 4 hours a day, 3 times a week. CPR, or cardiopulmonary resuscitation, consists of chest compressions and mouth-to-mouth resuscitation. Resuscitative efforts can restart an individual's breathing or heart if it's stopped, but it doesn't always work. Success rates are lower for individuals with advanced age or serious illness, and if it's successful for these type of individuals, they often are faced with a decrease in their functional ability. Blood transfusions are used to treat anemia or low blood count, and antibiotics are used to treat infections. Now, this is an important intervention that most people don't think about, but with end-stage dementia, people suffer for a very long time, often without a good quality of life. And they eventually end up hospitalized several times a year to receive IV antibiotics to treat urinary and respiratory infections. They're like frequent flyers coming in and out of the hospital, and they're weaker and sicker each time. So that's a very important life support that you need to consider when you're completing this advanced directive. Use the blank space to voice your opinion about what would be okay and what's too much, or add in things not listed. things you feel are unnecessary and aggressive medical interventions. Of course, you must consider your religious and personal beliefs. During our current healthcare crisis, I'm hearing tragic stories from my nursing colleagues on the front line because many medically fragile and elderly patients don't have an advance directive. The healthcare team must perform aggressive medical interventions, often causing a traumatic death. What makes this especially more difficult for the staff is during this time of crisis, they barely have a moment to spare to talk with the loved ones on the phone or FaceTime them to offer support, nor can they provide a gentle touch or hug. My colleagues are agonizing over the what ifs. What if patients were prepared and had conversations with their loved ones about what was important in the end? Certainly, their families would have felt less conflicted if they knew how they could have honored their loved ones' wishes. Wish 2 continues on page 7. Here, they present 3 end-of-life scenarios: close to death, in a coma and not expected to wake up or recover, permanent and severe brain damage. For each of these scenarios, you have to check off one of the 3 boxes. Number 1, I want to have life support treatment. Number 2, I don't want life support treatment, and if it was started, I want it stopped. Or, I want to have life support treatment if my doctor believes it can help, but I want my doctor to stop giving me life support treatment if it's not helping my health condition or symptoms. So, for example, if I were in a coma and not expected to wake up or recover, I would check off number 2. I don't want life support treatment, and if it was started, I want it stopped. The idea here is that you must carefully think through each of these scenarios. Then you should check off one of the options. Either number 1, I want to have life support. Number 2, I don't want life support, and then if it was started, I want it stopped. And number 3, I want to have life support treatment if my doctor believes it can help, but I want my doctor to stop giving me life support treatment if it's not helping my health condition or symptoms. At the bottom of the page, you'll see a blank area. Here you can insert your thoughts or a condition not mentioned. Things like end-stage dementia, heart, or renal failure. So let me share another true story of why it's important to document one's advance directive. It's another story. I was requested in the ICU to meet with the family of a 95-year-old woman with heart failure, diabetes, and end-stage dementia. She had suffered a stroke. She had been intubated and placed on a ventilator, and her kidneys were beginning to fail. The healthcare team was contemplating dialysis. There was no advance directive in place, and she had never spoken with her family about how she wanted to be treated at the end of her life. So when I met with the family, they were distraught and conflicted about what type of interventions to consider, if any. This scenario would have gone differently had there been end-of-life discussions and/or a do not resuscitate order. If there had been a DNR order in place for this 95-year-old woman, the healthcare staff would not have defaulted to the usual medical interventions, like the ventilator, or even consider dialysis. The family's anguish was tragic. They didn't know what to do, and they felt pressure to make a decision without knowing what their loved one would have wanted. They had no idea how to direct the healthcare team. Unfortunately, this scene happens all too often.
Yeah, pretty heavy stuff. So let's take a little breather before moving on to wishes 3, 4, and 5. And in this moment, I'm going to tell you a story. And it's my story, my personal story. So when I first began advocating for death literacy, my family and friends looked on in absolute horror. They did not understand what had come over me. I simply wanted to address the elephant in the room, pierce the veil of fear, that taboo. Well, my first up-close experience with death happened when I was 22. While driving my younger sister to school on a snowy March morning, my mother's car hit a patch of ice and skidded into the oncoming lane. The car was broadsided, she died instantly, and my sister lived on, but suffered a very long and tortured recovery. Somewhere in the messy aftermath, my father tasked me with cleaning out my mom's effects. Dad just could not deal with his emotions, so we, everyone in the household, had to just move on. There was no discussing what had happened. Fast forward 30 years. My father's second wife passes peacefully in her sleep. After about 6 months, I gently broached the topic about his end-of-life plans. Despite now his experiences and his rapidly declining health, once again, he wanted no part of this discussion. After that, I conspired with my brother to put as many things into motion as we could with and without his consent. In the end, my father endured many aggressive interventions and multiple hospitalizations because he didn't want to talk about end of life, his death. That experience was the instigation that gave me the courage to prepare, but long before the end. It also left my brother and I and other family members with a lot of trauma, something I definitely wanted to avoid. So, no one wants to talk about end of life. It's very triggering. It brings up a host of unwelcome emotions. But having seen and heard now way too many bad death stories is what inspired me to become a vocal advocate for death literacy programming. Programming that becomes gentle conversation starters that encourage other people to advocate for better outcomes. A few examples of these kinds of programmings include the annual Aging in Film series at Montclair Film, the Long Before the End book group chapters, and webinars like this. Personal experience is what gives you the courage and to get past your fear and resistance to deliver a gift to those who will be caring for you at the end. It's just something you want to think about. Now, I did my first advanced directive in 2015. Not having any medical training, I struggled filling out the form, and I remember thinking, why is this so hard? It's been about 5 years. Well, actually, exactly 5 years, and much has changed when I first put pen to paper. In addition to all the learning that I acquired from others in the field, life threw me a curveball, and I became my own case study. Out of the blue, my husband was diagnosed with asymptomatic multiple myeloma. Updating our advanced directives and my advanced directives was critical as well as comforting. His medical journey opened up a whole new decision tree for him, myself, and our family. It's taken my family several years and multiple conversations to really address the elephant in the room without them running out of the room. You might say I wore them down, but I'd prefer to think that it was when they realized that where we were coming from was a place of love, a place that considered something that would ease their emotional burden when it was their time to say goodbye. So, with that, I'd like to switch back to Tacey and review wishes 3, 4, and 5.
Thanks, Karen. So wishes 3, 4, and 5 are on pages 8 and 9. These wishes focus on one's personal, emotional, and spiritual needs. In this section, all you must do is cross off any actions you do not want your loved ones to do. Let's get to there. So wish number 3, it's about comfort. It includes things like how you want your pain, depression, or nausea addressed. If you want your favorite music played or be massaged with warm oils. A very important point is to be specific about how you want your pain managed. Some people do not want to be in pain, and they don't care if the pain medication causes them to be drowsy. However, I've observed families in conflict at the end of life because some families want their loved ones to be more alert and not sedated because they want to be able to communicate with them while their loved one suffers in pain. Just make sure you're clear about how you want your pain managed. And remember, in these sections, read each intervention and cross out anything that you do not agree with. We're going to be moving on now to wish number 4, which is how you want people to treat you. For example, do you always want people present with you? Your handheld? Do you want prayer? Do you want to die at home? Read each of these actions and cross off anything you do not want. Wish number 5 is what you want your loved ones to know. For example, I want them to know I love them. I want them to respect my end-of-life wishes, even though they may not agree with them. This wish includes your funeral, memorial wishes. In this section, just cross off any actions you do not want your loved ones to do. And like the previous wishes, there's a space on page 9 to write in any other wishes that may not have been addressed yet. Feel free to write them in here. Okay, we're almost done. Remember to submit any questions using the chat function. So let's turn to page 10 and 11. In order to make this a legal document, you must sign it and have 2 witnesses not related to you sign. Your healthcare agent should not be one of your witnesses, and you do not need to get it notarized or signed by an attorney. That's the beauty of this form. Once signed, your advance directive document is legal. Next, I'd like for you to make several copies. One for you, one for your healthcare agent or family members, and your primary care provider. And now that you've completed it, it's important you schedule time to review your wishes with family and healthcare providers. Now, I know that this is not easy. These conversations can be uncomfortable. I've heard many approaches, but the most common one is to call a meeting, a family meeting, and then review this document with them. And don't forget to complete the wallet card on page 11, which includes where one can find your 5 wishes document. And don't store your 5 wishes in your safety security deposit box. Instead, make sure it's easily accessible. That's it. Congratulations. You've reviewed the 5 wishes.
Okay. So, is everyone breathing? We can turn off mute now because we're going to go into the Q&A. So take your mute off. Either if Tacey could do it globally, great. Otherwise, would everyone come back? We want to unmute.
All right, everyone should be. I'm gonna go around and unmute everyone.
And unmute ourselves.
I just did.
Oh.
Does anyone have a question they want to ask in addition to typing it in? We know each other pretty well.
So if you're on life support treatment, does that imply that you no longer can make any decisions for yourself?
If you're not, can I answer that? You have to be cognitively competent, and the doctor will decide whether or not you are. Because you could, if you're still cognitively there, you could still say yes or no. But the advance directive is really there in case you're not cognitively there and unable to speak on your behalf.
We have to make that clear in the document,
Which part?
the cognitive, okay.
No, that's something that's very clear in the hospital setting. In terms of the doctors will say that this person is competent to make their own decisions. It will be documented. If you're not able to make your decisions, that would also be documented there.
Thank you.
I have a question.
How common is it for healthcare professionals, like in a nursing home, to disregard DNRs and things of that sort? I mean, this happened with my uncle. He was vegetative, and they sent him to the hospital at the last, it was ridiculous, and he did have a DNR. Are hospitals better about, and this was a long time ago, are hospitals better about, and care providers better about observing the wishes of the patient?
I would say that was very unfortunate. There's the DNR usually are posted right in the front of the chart, and it's also written as a physician's order. So that was really a horrible oversight. I've not heard of that happening in the hospital setting where I have worked.
I have to say, I'm sorry. I've seen DNRs posted over the patient's bed, so you really can't miss it. It's not a chart thing at all. When people are dying at home, and there are lots of people from hospice or medical people going in and out, this is the don't call an ambulance notice.
Yeah, there's a specific form called the out of hospital do not resuscitate form. That's the only form that the EMS will pay attention to. Even if you ran after them with a living will or 5 wishes with the do not resuscitate on it, they still have to, by law, begin CPR. So, if your loved one is wanting to be a do not resuscitate, make sure that form in New Jersey, they must have that out of hospital DNR form. It's a green form that we tell people to leave on there somewhere visible, either near the door, on the refrigerator, so that if someone accidentally, they freak out and they call 911, the EMS people will see it and then not continue with CPR.
Where do you get it?
Part of the, yeah, right. This isn't part of the 5 wishes?
No, that would be something you get from your doctor. I believe it's on the Department of Health New Jersey website, but your doctor has to sign it.
I have a question. I don't know. Can I ask?
Yes.
Yeah.
Hi.
Okay. So my husband and I are wondering, how are people handling this in the age of COVID? So here we are in our 60s, not in our 80s or 90s, and supposing somehow you ended up on a ventilator, but at this age you might want to be on that ventilator with having the choice of coming off, but it wouldn't be the same directive you would have if you were older.
So why we really like to stress the importance of having conversations with your loved ones. Because even if you don't have an advance directive, the doctor is going to be reaching out to a spouse, to a partner, to discuss what they have, a goals of care conversation with the family members. To say, okay, this is what's happening, and what do you think she would want? These are the pros, these are the cons. We think that she has a chance of surviving. They'll have a discussion if you do not have an advance directive.
And would that family member still have the ability then to take the person off the ventilator if it just seemed like it was ongoing and not the person wasn't going to recover? Okay.
Yeah, that's happening today because There have been people that were placed on a ventilator at the beginning of this, and my colleagues now are saying they're doing these compassionate weans where it's been 30, 40, 60 days, nothing's happening. And so they're discontinuing based on that they're, not going to get any better.
Thank you.
I'd like to just speak to the importance of this at this moment. I mean, kind of one of the horrifying things that I know we've all heard is really about should this virus come to us, if we get it, we're going to the hospital alone, maybe with this. There's no family member coming, your healthcare proxy's not coming in. There's a lot of communication back and forth between emergency personnel and the patient and a cell phone and all that. But this is the moment that you need a piece of paper to speak to the medical staff. With luck, they're going to be reaching out to the phone numbers you give them, the family members, but it's a very, very different situation. And I actually think that it is possible, in addition to talking to family members about this disease and this scenario, as we've heard it over and over again, it is possible also to write something. I put something in my little envelope here that said, do not get on a plane and try to come here if I go into the hospital. I am sure you will be able to find the emergency room people that you need, because to put everybody else at risk just to get information about me, it's not what I wanted. And it's sort of like, in playing that out, everybody could come out in a different place, but it sort of underscores why, you stick this in your bag and you take it with you. They're going to pay attention to it because it is the life-threatening moment that they have to make a judgment about, possibly in your absence.
Could you talk about the challenges of acceding to the wish for dying at home? There are all sorts of articles in the Times recently about how very challenging it is for the spouse or caretaker, if they don't have the means for round-the-clock care. Could you talk about that?
Well, let's make no mistake. I have so many colleagues who are in the end of life arena, and they absolutely, without any unvarnished tale, talk about how shocking it is for the family to, like, when someone who is dying is on a hospice and they say, and the wish is, I want to die at home. And of course you want to accommodate that person that they die in the comfort of their home. But without care, professional care, being a spouse or a family member and becoming an untrained caregiver is really, really hard. This in itself has given rise to the death doula movement, because a significant number of death doulas and end up being additional support. You have the RNs and you have the hospice team coming to the home, and you have people checking in, but it is not 24/7. It is not the hospital, and someone who is dying may need a lot of attention, and it's personally exhausting to the family. So learning about the death doula movement and finding a doula in your area would be a good thing. It's an additional helping hand and trained. Most of them are ex-nurses and or healthcare workers, and they've just shifted over because being independent and attending to people who are at the end of life has a significant amount of compassion without the kind of rules that you have to abide to when you're a part of an organization.
Karen, I've never heard of the death doula. Can you tell us more about how to find out about that?
Yes, what I will do as a follow-up is I will send out some links so that you can start looking into those. There's a lot of practitioners who are available. Obviously they'll either do it out of the kindness of their heart, but this is also their income. So they charge a nominal fee, but they're extremely valuable. And I will put together a little resource for you and send it out to everyone on the
Thank you.
call.
That would be helpful.
Tacey, you want to add anything to that about end-of-life support at home?
Yeah, unfortunately, in the state of New Jersey, we don't have, like in New York City, they have, 24-hour home health aid services for those who, are on Medicaid. But yeah, that is one of the biggest complaints about end-of-life care at home, is that you have to privately pay for a home health aid if the services that hospice is providing, which are pretty intermittent. The hospice movement, when it was created, was really about teaching the families how to care for their loved ones at home. Hospice does cover, all the disciplines, and it includes like the hospital durable medical equipment, any medications that are needed to keep you comfortable at home, but it does not cover the home health aid services around the clock as most people are going to need. So what I see oftentimes is that people end up in a nursing home on hospice. That's really not the best type of care to provide, but if you can't afford 24-hour home health aid services at home, that's where people end up.
Would a long-term care policy usually cover the home health aid during, the final illness?
Yes, I have to say, just from my experience with my mother-in-law and my father-in-law. My mother-in-law was on hospice in the city, and we hired around-the-clock home health aids, and we were able to get reimbursed for that, for the cost. And again, it depends on every long-term care policy and how much you've bought and how much is given per diem. But yes, it does cover the home health aid services.
Okay.
I wouldn't mind adding also that sometimes, like with Tacey's mom and dad, the extended family had an amazing experience coming together for what was short. It was 10 days, 2 weeks kind of thing, but we did an end of life time with each other that was mind-boggling. It was so beautiful, and it was emotionally connecting, and it was really incredible. We were all together pretty much for the 10 days, and we got to share stories, and we got to sing, and they were doing dancing, and I mean, it was just amazing. And it was, the brothers, the sister, the extended family, people would come in and out after work, and some of us stayed the whole time, and then both her mom and then both her dad and then her mom died. It was a beautiful experience. So, the family, and I did it with my mom too. I just think it can be really amazing. I asked a question in the chat if you wanted to answer.
I think that's a very funny question. Is there a better disease to die from?
Let me see.
Like, yeah, in your sleep.
That's right.
Exactly, that's what I was getting at. Are
Exactly.
there
Yes. I call that, when you die in your sleep, I termed that the Disney death, It's when, everyone's around you and you just close your eyes and you just go away, and then the tear goes away, and then everyone has a wonderful experience of your end of life, and we should be so lucky.
So it was a setup in a way, but I mean, it's a real legitimate thing, because when my mom, was going on and on and on and not dying.
And she had dementia. Mm-hmm.
And she had, terrible dementia. And really, like, had she just gotten a bladder infection and we didn't treat it, then she would have gotten what we call septic. The blood would have gotten infected, and then you go to sleep and you don't wake up. Like, that's a good thing. Like, you would think a bladder infection couldn't cause that, but like I learned then in 2010, okay, so I wouldn't want antibiotics, which seems such a simple thing, because that's a great way to die, right? So there are better and worse ways, you know, things where you can't breathe. That seems scary to me versus like, you know, blood deaths where you just get unconscious. That seems good to me. You know, that's what I was asking about, like that.
I'm just gonna,
I don't know who's speaking. It's breaking
not a
up.
pleasant
Who's
way to
speaking?
go.
We're having trouble hearing you.
Sorry. You hear me?
Oh, hiya.
No, we can't.
Yeah,
Okay.
kind of.
My grandfather had ALS, you know, Lou Gehrig's disease. So not a pleasant way to go. But he said, dying in your sleep, that's living.
Yeah.
There you are.
Let's see if there's any more questions. Is it, Andrea, is it beneficial to talk with multiple family members and not just a healthcare proxy to know more? You're thinking, of course. I mean, start with your family. You know, it really depends on your relationship and the resistance and or openness in which you can hold this conversation. You could pick them off one at a time. You know, you can go after the strongest voice in the room that may be an adult child or you know, a sibling, and have that conversation, and then use that person to endorse the validity of the conversation so that they would pass it along and open up the door to somebody who may not be willing to easily accommodate your desire to talk about this. But again, if your family, if you want to bring them all in a room, and
Well, we're in a weird situation because if you're going to talk to them, it's
you
probably
can't.
going to be like this. All
Yeah.
right.
And then Zoom.
And so, you know, some of this works to our advantage is my feeling, because you can send them the 5 wishes and you can say Sunday night, be there, you know, but how you talk about it and the humor that's there and the cocktail you need to have or whatever makes it possible, is the discussion. And it does not need to be the final discussion. It may be that you have a preliminary discussion and then you come back to it, having thought about it and talked about it. I would disagree with what Tacey said in terms of you can have 2 people as your healthcare proxy if they agree. I think legally you can have a primary and you can have a successor, and they should agree, because legally, if there's a medical decision that has to be made, it has to be one or the other. To get those 2 people to sign off is a difficult legal proposition. But you know, it is really about getting people on the same page. And I think Tacey capably introduced the problem of the people you feel the closest to might not be the best advocates at that moment. They might not be able to be the slightly arm's length strategy people you need. But you know, I'm sorry, somebody says something, but it's worth you know, exploring and thinking through.
Sorry, I thought I had turned it off.
so I want to add something to that, Andrea. So this is based on real stories. I'm not going to name names, but there's a term that people in the end of life care space, not necessarily RNs, you know, within the official healthcare organizational environment, but like the death doulas and or chaplains, they call something like, well, they'll have a situation and they'll say, oh, it's the daughter from California calling. And that's a euphemism. And what that means is one of the parents is hospitalized and in dire condition, near death. And there's been the adult children or the local family around, and they may even be in the room or constantly present. And they understand and heard, let's say mom, what mom wanted. They know what mom wanted. And mom's not able to talk and speak anymore and represent herself. But the core family that's been hyperlocal says that's not what mom wanted or what mom wanted. And then there's the quote unquote daughter from California who calls, that starts bossing people around, the medical team, and saying, no, you can't do that. And without a very clear advance directive, the medical team is really taxed and at odds with how to respond. And they play it safe a lot of the time to not put themselves in a legal situation, an aggressive legal situation, because someone, a family member, there wasn't consensus. Another reason why you want an advance directive.
Good points.
So let's see if there's any more questions here.
Was
I would just like
everyone
to point out,
able?
some of the people may not have been able to print out this booklet.
Yes.
And if that's true,
Tell me
Tacey
who
can,
they are. I can send you.
well, Tacey can advise you how to do it. And this organization, Aging with Dignity, is the master, the author of this. And this is used around the world. I mean, this is the advanced directive with the heart, because it really allows you as a workbook to sit down and think about those things. And it's not a strictly legal document in that sense. The fact that it's witnessed and signed at the end, that's it, it's done. And that's a big help to know. You know, I personally actually suggest, you know, doing it, getting it out of the way, but then every few years you look at it and do it again. If your health situation changes, if your children move someplace far away, I mean, there are lots of reasons to evaluate this. And it's it's an ongoing discussion. And as Karen talks about, you know, my children are a perfect example. Their ability to talk about this is not so high. And, you know, I have put it in their face and they know about it. And maybe it's a family joke, but, you know, they don't think it's rude anymore. They just listen to it. And I think they're learning from it. I think, you know, particularly in this bizarre twist of world events here, the notion of control over life and death is something that they, in their 30s, have started to think about. I wasn't thinking about it.
Right.
So I encourage talking and then talking again.
Yes.
I also would say, you know, we all know each other. We have a community. This is something we could get together and talk about as a, you know, if it were helpful to do that. And just because it's, you know, we're one step closer to just kind of kicking it around, which is sort of what we're doing here.
I have a question.
I really liked your, Andrea, I really liked your caveat in these times to tell the kids there's no point in getting on a plane and endangering yourself.
Of course.
Well, that really hit me really early. It was kind of like, you know, that
There's
was
nothing
so
you
out
can
of,
Right.
who it's, you know, and the idea of going to a hospital alone, I've been in a hospital a lot of times, but never alone. So it's a whole new ball game, you know, to go with my cell phone and an extra battery maybe, but you know, it's a very different thing. And just like we did when we were pregnant and about to deliver babies, you know, we thought about the carry bag, you know, I mean, and it's a horrible time, but this offers some amount of rational thought. And
Yeah, and in this time, when you bring up the conversation with your family, it's the kind of thing where it's not such a bad idea, even though they cannot imagine, you know, a younger generation, your adult children, like, why would they need it? They may have their will, they may have the legal documents, but encourage them to also do theirs, right? If you're going on a trip, if you're going on a major trip, if you're having a baby, you know, and there's so many different reasons to have something in place. I had a conversation several months ago with a 30-something-year-old who is very close to marrying a relative, okay? And I started talking about this, and I could see the body language stiffen up. And she said to me, well, I don't need to do this. If if I die, my mother will take care of me. And I said to her, that's probably true, but wouldn't it be nice for you to understand what the options are and give her some help? She goes, I don't want to know about it. Let her take care of the problem. Okay. So it's the kind of thing really where you pay it forward. If you have adult children, pay it forward, introduce it to them now. It's hard for them to think that we're going to disappear off the face of the earth, but maybe they're of the generation where they think a lot about themselves and they can start thinking about their own mortality, and especially given that we're dealing with COVID. That's all.
I've always said that having that advance directive is like giving a gift to your family, because I've met with so many distraught families at the end because that person really never talked about it. And so they're all left not knowing what are they supposed to do? What do you think they would want the healthcare team to do? So if you can think of it that way as a gift that you're giving to your loved ones who are having to make these difficult decisions, that might give you the impetus to complete one.
Yeah, that's right.
I have a question. I wonder, within the scope of your practice within New Jersey, if you have any recommendations for attorneys for end of life, estate planning, etc. And if you do, can I just ask you to write to me then?
Sure.
Yeah, there are several. There's a member of our congregation who does it as a regular matter. And the other thing I would throw out there, though it's not part of this document, it is available, is that there is now a dementia healthcare proxy that is rather specifically about losing your wits, losing your cognitive grasp. And it raises a whole bunch of other issues. And I actually talked to this lawyer and said, shouldn't this be part of it? And she said, I just put it into my regular form because it is so clearly the thing. How many times have we just mentioned Alzheimer's or dementia in this conversation that it doesn't merit a sort of attention on its own? That doesn't mean don't do this, but there are separate documents that are the dementia end of life documents.
Right.
So yes, I will be happy to give you a name or two.
Thank you so much.
Okay. So are we almost ready to sign off here?
Thank you very much.
So first, let us thank you. Thank you for coming, and thank you, B'nai Keshet, for inviting us to have this conversation with you, and to Andrea for your wonderful intro. One more thing. Yes. So well, I hope you feel comfortable taking the next step of completing your advance directive in the next couple of weeks, days or weeks. If you have any questions, please feel free to reach out to us. The information is up there. And if you want to learn more about death literacy, please follow us on social, as well as sign up on the Vival website for our very occasional newsletter. But there's a bunch of information there, which is thoughtful. And it can show you what's going on from thought leaders and other people as to how they're approaching end of life as a topic. And then finally, we're going to be sending out a survey. It's literally under a minute. Under a minute. Please just take a moment to check the boxes and give us some feedback. That would be really helpful.
Are you planning?
Thank you. Thank you.
Karen, are you planning any movies?
Oh, the movie. Well, as soon as they open up the theater.
Well,
yeah.
what about remotely?
We could do that. We could do that. What makes it a little bit awkward is bringing in the guests on a remote basis.
By Zoom. Oh,
yeah, just booking these people. They're much happier to sit in front of a room than have another Zoom call.
All right.
Understandable.
Definitely in the planning.
Wonderful. Thank you so much.
Thank you for asking.
Thank you.
Thank you so
much. Thank you.
Very helpful. Thank you.
You're
Take
welcome.
good care, everybody. Be well.
Bye.
Bye.